Hola, muy buenos días, buenas
Good
tardes.
morning, good afternoon, and thank you for joining this press briefing organized by the Pan American Health Organization on the COVID-19 pandemic in the region of the Americas on this Wednesday, October 6th. My name is Sebastián Oliel with the Communications Department at PAHO, and this session will be about an hour long. Please remember that you can send us your questions using the Q&A button, and we have also received questions through email, and please indicate your name and media outlet when sending your questions. Let me remind you that we have simultaneous interpretation into English, Portuguese, and French, as well as Spanish, and that you can choose the language with the interpretation button. Today, Dr. Carissa Etienne, PAHO's director, will be reporting on the evolution of the pandemic vaccination in the Americas, and she will also be referring to the need to strengthen the links between human beings, animals, and the environment to manage future health crises. Together with Dr. Etienne, we have Dr. Jarvas Barbosa, Assistant Director of PAHO, Dr. Ciro Ugarte, Health Emergencies Chief, and Dr. Sylvain Aldiguiere, Incident Manager for COVID-19 at PAHO. Now, I would like to give the floor to Dr. Etienne to share her opening remarks and regional update. Dr. Etienne.
Good morning, and thank you, Sebastian. Let me thank sincerely all of you who have joined today's press briefing. For the last month, we have seen COVID infections drop throughout the region, even if cases remain high. Over the last week, nearly 1.2 million COVID-19 cases and 24,000 COVID-related deaths were reported in the Americas. In North America, while cases are down in the US and Canada, Mexico is reporting a jump in new infections. But national data doesn't tell us the whole story. If we look deeper, we see that local trends remain worrisome. Many southwestern Canadian provinces are reaching their highest hospitalization and ICU peaks since the beginning of the pandemic. And in the state of Alaska, which today reports the US's worst COVID outbreak, emergency rooms are overwhelmed with COVID. Patients and doctors face difficult choices about how to allocate hospital beds. Across the Caribbean, infections are going down overall, although Cuba and Bermuda continue to report high rates of new infections, and Barbados saw cases increase by nearly 75% over the last week. In Central America, while cases are decreasing throughout the subregion, Costa Rica continues to see high rates of hospitalization and ICU bed use. Hospitalizations have also jumped by 2/3 in Belize. In South America, while countries are continuing to see a drop in infections, Chile is seeing a jump in new cases, driven primarily by outbreaks in urban centers like the metropolitan region of Santiago and the port cities of Coquimba and Antofagasta. As we look across the region, we are reminded that governments need to keep a close eye on local trends because infection dynamics vary widely within each country, in part due to differences in vaccine availability and uptake. This more localized approach will be key to keeping outbreaks under control. Today, just 37% of people in Latin America and the Caribbean have been fully vaccinated against COVID-19. As 7 countries and territories in the Americas have vaccinated more than 70% of their populations, just as many have yet to vaccinate 20% of their populations. Jamaica, Nicaragua, and Haiti have yet to reach even 10% coverage. We must focus our attention to close this gap as quickly as possible. In just the past week, 875,000 vaccine doses arrived in countries across Latin America and the Caribbean. But we know these are not enough to protect everyone. So we continue to urge countries with surplus doses to share this with countries in our region where they can have life-saving impact. Let me assure you that PAHO is doing everything it can to accelerate vaccinations in the Americas, from delivering COVAX doses to supporting donations to purchasing vaccines on behalf of our region and establishing a platform to ramp up vaccine manufacturing in our region. I am pleased to announce that PAHO has already closed agreements with 3 emergency use listing authorized producers: Sinovac, Sinopharm, and AstraZeneca. We are now in conversation with our member states that want to use this alternative for direct purchasing through the revolving fund. We now have vaccines from Sinovac and AstraZeneca available this year, and also from the 3 producers to 2022. Whether it's getting vaccines to our region or tracking the spread of variants, controlling this pandemic rests on the work and support of partners across our region and indeed the world. And just as we work together to control this pandemic, we must consider the ways in which we can collaborate to avoid future pandemics. COVID-19 has been unique in its scale and impact, but it is not the first emerging disease to cause ripple effects throughout the world. Whether it's COVID-19, Ebola, chikungunya, yellow fever, avian influenza, or Zika, we've seen that diseases that spill from animals to people can have severe impacts. We have a list of emerging pathogens that have the potential for public health risk, and almost all of those are either zoonotic, meaning that they can transmit from animals to people, or common to humans and animals. As climate change impacts ecosystems, and as people come into closer contact with animals via urbanization and deforestation, the potential for spillover is increasing. The health sector plays a critical role in managing this risk, but it can't do it alone. And that's why it is crucial that pandemic plans and policies reflect the expertise and the recommendations of public health, animal health, and environmental sectors. This is especially critical in a region like our own, which has tropical zones with high potential to harbor new diseases like the Amazon Basin, Gran Chaco, the Lacandon jungle, the Darien Isthmus, and La Mosquita. The economies of many countries in the Americas also rely heavily on agricultural production and exportation. So the threat of animal diseases looms large and has the potential to impact entire industries and national development. And of course, the risk for a new pandemic. A One Health approach has long been a priority for PAHO. For more than 70 years, PAHO has hosted a veterinary public health program that works with both public health and animal health sectors on zoonotic diseases and food safety. In the late 1990s, PAHO developed a strategy for strengthening surveillance of emerging infectious diseases that includes the human-animal interface. And that is a defining feature of One Health. Our integrated surveillance leverages animal health institutes to monitor animal and human diseases, conduct joint risk assessments, and host workshops and trainings on issues like yellow fever. Recently, ministers of health at our directing council approved a new One Health policy that outlines a blueprint for countries to bring together experts and officials from across sectors to address some of the most challenging issues of our time, including zoonotic diseases, food safety, antimicrobial resistance, and climate change. We need countries to ensure that animal, agricultural, and environmental partners are brought to the table to build more robust surveillance systems that can detect risk faster, prioritize investments in research and development for high-risk pathogens, and establish strong pandemic responses that build on the strengths of these diverse areas of expertise. Because the cost of preventing a pandemic is much less than the cost of responding to one. COVID-19 alone has caused a loss of some $4 trillion in global GDP, and we're not yet out of the woods. So in the months ahead, as countries revisit their health budgets, rethink how they deliver healthcare, and engage in global efforts to prevent the next pandemic, we want to urge everyone to build on this One Health approach as the smartest, most effective way to protect ourselves from the next crisis that can lead to a global pandemic. Let me thank you again, and over.
Muchas gracias, doctora Etienne. Vamos a pasar ahora
Thank you,
entonces
Dr. Etienne. Now we are going to start answering the questions that we have received via email and that we received through the Q&A and the chat. Please do include your question with your name and media outlet. The first questions have to do with the vaccination of children and teenagers. Adrian Aguirre from sumedico.com is asking, what are the recommendations to vaccinate children against COVID-19? And he's saying that in Mexico, only teenagers between 12 and 17 years of age with comorbidities will be vaccinated. And the question is whether younger children should be vaccinated. And also Irene Hartman from Clarín, Argentina, is saying that Argentina approved the use of the Sinopharm vaccine for children as of 3 years of age, beyond the fact that there are no preliminary data of phase 3 available for children younger than 17. And she's asking, what is the opinion about the countries that are adopting this type of strategy and whether the pediatric use of vaccines such as Sinopharm is being reviewed? Dr. Barbosa, thank you very much. These are many questions at the same time, but first of all, a vaccine to be used in children and teenagers need to have the authorization by the regulatory authority within the country. In Mexico, COFEPRIS, in Argentina, ANMAT, and in the other countries of the region, the regulatory authorities need to provide the information, and based on the information, first, the producer has to present information to the regulatory authorities, and the authorities are the ones that are to approve it for administration in children and teenagers. As to WHO has authorized Pfizer for teenagers, Sinopharm, Moderna are being reviewed, and in short, we will have the completed analysis for a recommendation also for those age groups. That is for the authorization. As to use, this vaccine strategies need to have very clear goals. For COVID-19, the first goal of the vaccines was to save lives. And since the elderly are the ones that are at greater risk of developing a severe form of COVID-19 and dying, the recommendation by WHO was to use vaccines to protect the elderly and also to protect health professionals, health workers, to maintain the operation of the services. And then it can be expanded to all of the adult groups. And this is what the countries are doing for adolescents and children. It was not a priority because most of the severe cases, most of the deaths were among the adult population and the elderly. The countries have different vaccine coverages. So a country that has already vaccinated all of the adult population and it has vaccinations available and vaccines available and vaccines that are available for teenagers should start vaccinating teenagers, in particular those that have comorbidities first, because that's where we have the greatest risk. This is a general recommendation that we have. The countries need to have phases so that they do not vaccinate lower risk groups before completing vaccination in higher risk groups.
Fundamentada por la disponibilidade de vacunas que
The
tienen.
countries need to have enough vaccines, so the countries are adopting the strategies that are best based on the current situation. And after vaccinating all of the adults, the next group should be teenagers with the vaccines authorized by their own regulatory authorities. Thank you. Thank you, Doctor. The next question by Daniel Collin from TN23 in Guatemala. He's saying that Guatemala has started to see a drop in the number of positive cases, and he's asking what are the actions to be maintained to avoid a fourth wave, taking into account that we are close to the holidays. Dr. Ugarte. Thank you, Daniel, for the question. This is also common in several other countries in the region. Over the last 2 weeks, we have seen a drop in the number of confirmed cases and also in the number of positive results in Guatemala. This is a variable result based on the departments in the country. This evolution has been seen in Guatemala and in different countries, and this led to also more flexibility in public health measures, and also then the overwhelmed situation with the hospitals, with the health facilities, because and also other diseases that cannot be addressed because of the high number of COVID-19 patients. It might be a good idea to continue with active surveillance and also monitoring the capacity of the health facilities, in particular at the local level, because that is where we can implement the right measures to reduce transmission. This as vaccination increases against COVID-19. And in Guatemala, the current alerts through the traffic light system are the best reference for the population. It is also important to know that at all levels of the health system, in particular at the national level, there needs to be an assessment of the evidence availability, medicine, supplies, as well as the response plans at the hospital level, because we have also seen in many cases that the rise in the number of cases takes place at specific moments in time in specific areas, and a rapid response is required given the outbreaks to be controlled, to be addressed in time, and also have proper preparation. This will be even more important during the holiday season, the approaching holiday season, because clearly there will be an increase in the number of individuals traveling around and also the likelihood of transmission. And if we have learned anything, it is that when we implement public health measures that are relatively known, such as wearing masks at all times and also avoiding spaces where it is impossible to have physical distancing, and if possible, maintain physical distancing, and at the same time protect by washing hands and avoiding large crowds. All of that has shown to prevent the transmission of the virus, not only of the original virus, but also of the variants. And these measures will continue to be the best option as long as the pandemic continues to control and reduce transmission. Thank you. Thank you, Doctor. The next questions are by Royston Jones from Eyewitness News in Bahamas, and in English they are:
from the Bahamas returned with positive results of the Delta plus or Gamma variant. The Bahamas continues to experience a high positivity rate of between 19 to 26% daily and has around 30% of the population fully vaccinated. Based on WHO's recommendation of 5% for this indicator, what does this suggest for the country? Dr. Aldiguieri?
Thank you for this question from the Bahamas. First, it's very important to clarify that the Delta plus denomination does not exist. It was a name assumed by some media to refer to a Delta variant of concern, which with some additional mutations, but they are all classified only as Delta. It's important to say that looking to these additional changes, it may help researchers to track the virus on a fine scale, but they do not imply any functional or biological difference. Regarding the situation of the circulation of variants in the Bahamas, the most recent samples sequenced at the Gorgas Institute in Panama and at the Fiocruz Foundation in Brazil through the PAHO Genomic Surveillance Network, this sequencing have demonstrated 50% of Delta, 45% of Alpha, and only 1.3% of Gamma. Although Delta is becoming predominant in most of the countries of the Caribbean. And in this context, it is important to remember that this process of displacement and replacement of strains or variants is an expected phenomenon which has been happening since very early in the pandemic and occurs, among other factors, because of a circulation of viruses that, like the Delta variant, are better adapted to the human host as part of their evolution process. Regarding the second part of the question and the situation in the Bahamas, it could be that less people are presenting for testing. Perhaps as vaccination is increasing, people are becoming more relaxed and are less likely to present for testing when they have been exposed. Even though the vaccine rollout is going well, people should continue to use the public health and social measures that we know work to prevent the spread of COVID-19, including all its variants. As an example, physical distancing, mask wearing, and washing, sanitizing, etc. So I hope I have answered the concern of the journalist in the Bahamas. Thank you.
Gracias, doctor. Siguiente pregunta.
Thank you, doctor. The next question is also related to Bahamas in the chat and in the Q&A. From the Tribune, we hear:
The Bahamas is running low on vaccines. What do you suggest it does? Is it due more from PAHO? Dr. Barbosa?
Thank you for this question. As the director has mentioned, PAHO is doing everything that's possible to increase the access of PAHO's member states to vaccines. In the case of Bahamas, we are working to expedite the process with COVAX. So the Bahamas will receive another 57,300,000 doses in the first week of November. Secondly, we are working with the US government and CARFA to expedite the donation of 4 million doses that the US government is donating to the Caribbean countries, and the Bahamas will receive also vaccines through this initiative. And we are also offering to all the countries in the region to complement their vaccines through a direct purchase process using the PAHO's revolving fund. As the director mentioned, we have now 3 agreements that were closed with 3 emergency use list authorized producers by WTO that are offering vaccines to be delivered in 2021 for the last quarter of this year. So we have all these possibilities and we are working with the government of the Bahamas to support them to have more access. It's crucial that every country in our region needs to have more access, because this is the best way, together with the public health measures, to control the transmission and to the society, the economy, come back to more normal times. Thank you.
Gracias, doctor. Siguiente pregunta es de Blanca Valadez del
Thank you,
diario.
doctor. The next question is by Blanca Valadez from Milenio in Mexico. She's saying that the goal of the Mexican government is to have by October 31st, all of the Mexicans 18 years of age and older to receive at least 1 dose of the vaccine. Given this, can we say that Mexico has control or will control the pandemic? She's also saying that the flu season is upon us, and she's saying, what is the behavior that we see in its interaction with COVID-19 and the Delta variant?
Thank you for your question from Mexico. In no way the pandemic will be dominated at a local, state, and national level, while the SARS-CoV-2 and its variants of concern continue to circulate in the Americas or globally. Almost all countries in the region, including Mexico, are reporting a community transmission, and we expect high situations of outbreaks in many areas of the continent, even into 2022 or thereafter. While vaccine coverage has increased, we should not presume that whether or not we have achieved the herd effect, and that's not what we should use to base our public health measures. And we invite all those who have not been vaccinated to go get vaccinated and to continue to enforce measures. There is no signs yet of increase of influenza in Mexico. The Sentinel surveillance system is activated. These reports are shared all the time with the PAHO. And in this context, we recommend people who are at risk, according to the established guidelines, to become vaccinated against influenza once the vaccine is available. I hope I have replied or have responded to your questions from Ms. Valadez from Milenio in Mexico. Thank you. Thank you, doctor. Next question is from Gebel Felmine from Guardian in Trinidad and Tobago. In English, it says,
4.5% of COVID-19 patients in hospitals are vaccinated. One of the points anti-vaxxers and vaccine hesitant people make is that you can still contract COVID-19 and spread it. In this context, has PAHO identified any cause why some vaccinated people are being hospitalized with COVID-19? Are they people with existing health conditions? Is the vaccine effective but less effective in people with existing health conditions? Dr. Barbosa?
Thank you for this question. You know that each vaccine has different efficacy rate. Every vaccine can have different process to develop immunization in people that get them. But in general, we know that no vaccine, it's not only against COVID-19, no vaccine has 100% efficacy rate. So some people will get the vaccine, but will not develop protection against the disease. It can be caused by some immune system characteristics that some people have. We know for sure that the elderly, they have a weak immune system, so the efficacy rate can be less than in the average population for them. So you have some very different reasons that one person can get the vaccine and not develop the protection. But let's look to the figure that you presented in your question. If we have 4.5% of hospitalized people that are vaccinated, we are talking about 95.5% of hospitalized people that are non-vaccinated. So it is another evidence that the vaccines are very important to reduce the severe cases, the hospitalizations, and deaths. This is happening not only in Latin America and the Caribbean, but in all countries in the world. The data that we have now are showing clearly that the countries that are still experiencing a very important transmission of COVID-19, the pandemic is very important among non-vaccinated, unvaccinated people. So the anti-vaxxers are using just the partial information that they have, because if you take the whole picture, you really can see that more than 90%, in this case, 95.5% of people hospitalized are the people that haven't received the vaccine. This is the same for deaths related to COVAX. So the best way to be protected is to take the vaccine. But it is still important to highlight that the vaccines, they have a double effect. The vaccine has an individual protection. So if you get the vaccine, probably you'll be protected against the disease, but the vaccines also have this collective effect. People that are vaccinated, they transmit less the disease, the virus. So if you have a very important immunization coverage in your community, in your city, in your state, in your country, the transmission of the virus will decline for sure. So you will also be protected, not only because you got the vaccine, but because other people also got the vaccine, and this will benefit everybody, your family, your community, your country. So the anti-vaxxers, they are not using the full information that is available, because the full information is totally against what they are sharing, the fake news that they are spreading.
Gracias, doctor. Siguiente pregunta viene de Ronnie Ríos.
Thank you, doctor. From Ronnie Rios, from El Periódico de Guatemala, and a question which is similar from Cyrus Sebert from Media Institute of the Caribbean. And the question is, what is the strategy to counteract resistance or resistance to vaccine due to political, religious, and other reasons? And do you have an estimate of the numbers in the America of people who are not being vaccinated and are hesitant?
You know, there's no doubt that we need to increase the level of vaccine acceptance in Latin America and the Caribbean, and to focus on convincing people to listen to the sources where there is truthful, scientifically based information and evidence. And very often, this is not found in the university of social media. While we still face a shortage of vaccines in many of our countries, what we are seeing is that in some areas, even when vaccines are available, persons are not coming forward. In many settings, vaccine hesitancy is assumed to be the cause of low uptake of vaccines. But on closer study, we see the greater importance of other factors, such as accessibility, availability, and quality of services. We must use a primary healthcare approach and reach out to people to get vaccinated. In some areas, for instance, where the elderly might have trouble getting to health centers, we should be sending vaccinators to their communities and homes, or providing transportation to take them to the facilities where vaccines are being handed out. Social factors such as personal beliefs and what friends, family, and the community believe, that also has a strong influence on vaccine acceptance. And we have to design responses that are specific to each of those contexts, targeted and comprehensive. PAHO is supporting programs that diagnose the barriers and implement the strategies that are needed to increase vaccine uptake. Clear communication, engagement with communities, and quality vaccination services which are accessible to the community are key to addressing low vaccine uptake. Effective public communications about the benefits and safety of vaccination contributes to building that confidence. It is critical that accurate information about vaccines is readily available, accessible, and endorsed by trusted sources and communities. The bottom line, however, is that vaccines work and save lives. You've just listened to Dr. Barbosa. You should get a vaccine and convince your loved ones to get vaccinated against COVID-19. Getting more vaccines and immunizing the eligible populations in our countries, combined with maintaining the public health measures to reduce infections, are really the keys to combating this pandemic. Please, let us go out and get vaccinated.
Gracias, doctora Etienne. Siguiente.
Thank you, Dr. Etienne. The next questions come from different journalists. Cynthia Torres from El Confidencial, Gisela Salomon from AP, and Andrea Espinosa from Expediente Público, among others. They say the Health Ministry of Nicaragua has approved the emergency use of vaccines against COVID-19 manufactured by Cuba, Abdala, Soberana 2, and Soberana Plus, to immunize children from 2 to 17 years of age. The questions are, what information does PAHO have of the safety of these vaccines, and if their efficacy being analyzed, and do you know when these results will be ready? Dr. Barbosa, thank you very much for your question. The decision to authorize a vaccine in a country is a sovereign decision by the health health authorities and regulation authorities of each country. PAHO does not grant authorization to the countries. Each country has its own authorities, national authorities, HAMAC in Argentina, COFEPRIS in Mexico, SEGMED in Cuba. These three are the reference national agencies. They are even regional agencies. And so they evaluate the documents submitted by the manufacturers to authorize the vaccine for PAHO in order to purchase through the revolving fund of PAHO. We do not use national authorities from Latin America or from North America, Canada, Europe. No, we only use those evaluations made by the pre-qualification team of WHO. So we can only talk about those vaccines that have already been evaluated by the WHO team and those that have already received the emergency use authorization or license for the COVID-19 vaccine. So we cannot talk about vaccines that have not completed this process. It's not that they are bad or good. It's simply that we cannot speak about them because we have not reviewed them, that our colleagues from Geneva have not reviewed as yet. Secondly, and also included in this question, is mention to Nicaragua. We are working very much with the Nicaraguan government to have more access to vaccines in Nicaragua. Nicaragua will be receiving 223,000 doses from Pfizer starting next week, and another 81,900 vaccines from Pfizer in October. And we're also working with donations for Nicaragua, donations made through COVAX. In the case of Nicaragua, there is a donation from Spain, 625,900 vaccines from AstraZeneca, and we are working to accelerate the process of arrival of these vaccines to Nicaragua. So I think that if you can better use the vaccines that are available in Nicaragua, but of course each country makes their own decisions. We have vaccines that have been authorized by WHO for children and adolescents, only the ones from Pfizer and Moderna. The others are still under study. Regarding the Soberana vaccine, we're supporting Cuba for it to participate in the pre-qualification process with WHO. We already had a meeting with the WHO team and the manufacturers, and we will have future meetings as well, because our interest is that all vaccines are able to participate in the WHO process for granting the emergency use authorization, because this will broaden the supply of vaccines that we are able to purchase through the revolving fund. So the decision of each country is based on their own sovereignty, based on their own regulatory agencies. But if all the manufacturers participate in the process with the WHO, then more vaccines will be available to the revolving fund, and we will have then a better assortment of vaccines eventually. Now we have from Uriel Velasquez from Despacho 505 from Nicaragua. They ask if PAHO already has a report from the Ministry of Health of Nicaragua regarding circulation of the variants of concern in their country. Dr. Aldeguerri, please. Thank you very much for your question about Nicaragua. Even though at this point in time we do not have information about the detection of variants of interest or variants of concern in Nicaragua, we do know that the National Laboratory of Public Health is making efforts to generate the necessary data, not only for surveillance, but also for the scientific community in general. On the other hand, it is important to mention that thanks to efforts from Central American countries, Guatemala, Honduras, El Salvador, Belize, Costa Rica, and the very efficient collaboration from the Gorgas Institute in Panama, it has been possible to demonstrate circulation of the variants alpha, gamma, delta, which are variants of concern in Central America. So we highlight the importance of maintaining and strengthening genomic sustained genomic surveillance that allows us to timely detect the entry and dissemination of variants of concern in the different areas. And PAHO will continue to work closely, very closely, with all the countries with this in mind and with this purpose. Thank you very much. Thank you very much, Doctor. Now, next question in our chat in the Q&A from Gisela Salomon from Associated Press. It says whether we could give more details about the vaccines that have been agreed with from Sinopharm and others, and how many will we have available? That we have those from Sinovac, which were announced by PAHO last week. And the question is, are these the only ones or are there more? And is there any country who has already expressed interest in these three different kinds of vaccines? Dr. Barbosa, thank you for your question. As our director mentioned in her initial remarks, We do have 3 agreements at this point in time. The director announced last week the first agreement with Sinovac, and we have also completed one with Sinopharm and one with AstraZeneca. The vaccines will be available by AstraZeneca and Sinovac. We have about 18,500,000 doses available for this year of 2021. And for the year 2022, the amounts are still being negotiated based on what the countries are requesting. So we are drawing the countries' attention so that they can please send their requests and their petitions during this week, because we have some available amounts for this year and for next year, but it all is related to the amount of doses requested by the countries. Where are they being manufactured? PAHO can only purchase vaccines that have received the emergency use license from WHO. So AstraZeneca vaccines will be those from the AstraZeneca plants which have been granted EULs. The same thing goes from Sinovac and from Sinopharm. So this is the process we always follow in the revolving fund. Vaccines must be pre-qualified. So AstraZeneca can offer them from any plant as long as those plants are the ones that have been received the EUL. And we hope that the countries consider this, because the more the orders we have and requests we have, this will be benefiting the smaller countries in the region who are going to receive vaccines with more accessible prices. Thank you. Thank you, Doctor. Next question from Garrick Alvarado from Newsday, from Trinidad and Tobago. He says authorities approved the opening of commercial areas and schools, but with the mandatory submission of vaccination cards. Does PAHO believe that these mandatory measures are correct, or do they are they against the people who don't want to be vaccinated?
After taking into consideration ethical and technical considerations and transmission levels, countries may consider relaxing some measures for individuals in line with either of the following criteria that were discussed and analyzed by WHO and PAHO. One of them is completion of full vaccination with one of the WHO emergency use listed vaccines or approved by a stringent regulatory authority, and at least 2 weeks after completion of the vaccination. The other one, it would be the SARS-CoV-2 infection confirmed by PCR within the past 6 months and no longer infectious as per WHO's criteria for releasing COVID-19 patients from isolation. And depending on the transmission level, there are some options for individualized measures for persons. For example, waiving quarantine following close contact with a confirmed COVID-19 case, waiving testing and all quarantine requirements in the context of international travel, and allowing congregating in indoor private settings with other fully vaccinated or recovered individuals without wearing masks and without applying physical distancing. But ultimately, the decision to authorize indoor gatherings or gatherings in commerce on public areas based on the vaccination certificate is assuming that the country or the institution accepts the risk of onwards transmission from vaccinated individuals, and that the ethical considerations from non-vaccinated persons have been taken into account. So in summary, before implementing individualized public health measures, governments and other institutions and authorities should reduce the barriers to vaccination, consider measures that least infringe the rights and liberties of non-vaccinated individuals, and consider options for non-vaccinated individuals as a result of the reliable negative COVID-19 tests and making tests accessible for all, or issuing, for example, immunity certificates for recovered individuals, as some countries have been doing. This may help ensure that measures for non-vaccinated individuals that in the context of low availability of vaccines are proportionate and as socially inclusive, that is to remove or reduce as possible the barriers that prevent people from participating in civil, social, and economic life. Meanwhile, the vaccination reaches the level of protection of the community. Thank you.
Gracias, doctor. Tenemos ahora...
Thank you, doctor. We have now several questions from Peru. Cris Vilches Hurtado from Zona País from El Comercio asks, what are the reasons why there's a delay in shipping of vaccines to Peru? And the question is, so far, how many doses of the total that have been contracted through this mechanism have been sent to Peru? And will they be sent this year or maybe next year now? And another question from Chris Vilches is that Peru has 42% of the population already received 2 doses of the vaccine. And within this context, they have started to give their 3rd dose to health care workers, and they want to know whether this is the correct measure to follow. Dr. Barbosa. Thank you. Thank you for your question. Unfortunately, the delay in shipments by COVAX, it's not only for Peru, but for all countries participating in this facility. There are many reasons. First of all, problems with some manufacturers who are not prioritizing the shipments for COVAX facility, but they prioritize their bilateral agreements, but because in those bilateral agreements, the vaccines are more expensive than the price they give for COVAX. Secondly, COVAX had a significant problem because one of the largest manufacturers for 2021, which is the Serum Institute from India, has been forbidden to export vaccines. So there are about 500 million doses outstanding that have not been delivered. So that's why most countries, and Peru included in there, only received about 30% of the vaccines that they contracted through the mechanism. Peru has received about 2.5 million doses of COVAX vaccines, and they have new vaccines that will be arriving in the country in the next few weeks through COVAX again. So it is important to learn this. PAHO has always said that the priority should be the lowest coverage of some countries to prioritize shipments, and COVAX has accepted this criterion, and therefore we're going to have the countries that are below 10% in the region, below 10% vaccine coverage will be receiving as a priority vaccines in October. And COVAX has said that they won't be able to deliver for the 20% of the population that they have committed to for the end of this year, but they will be close to that figure. They hope that by November and December, they will have sent many more vaccines, so more vaccines will be available, but it will take until the beginning of 2022 to meet all the contracts they signed with the countries. That's why PAHO is working, in addition to accelerating access through COVAX, to also seek for more donations. Donations have been essential during August and September so that countries were able to have more vaccines. And we're also offering the possibility of doing purchases of vaccines through the revolving fund directly, that all countries in the region can send their requests to the revolving fund of our organization. Excuse me. Regarding the third dose, I forgot that part of the question. Regarding the third dose, to this point, there is no recommendation by the group of experts from WHO, from the SAGE group. This is the strategic group of experts. They are currently reviewing all the data, and it takes time because, as I said before, it varies for each vaccine. There are some vaccines that may reduce protection over 6 months, 8 months, a year. Other vaccines will take longer. So we cannot make a general, a blanket recommendation. We know that healthcare workers are a priority group, as well as older individuals. And each country is making their recommendations based on the vaccines that they have used and on the data they have, as well as the availability of vaccines they have. Because you cannot make a blanket recommendation, oh yeah, start giving the third dose, because in many countries, unfortunately, there are still people from priority groups who have not have access to the first dose. So each country need to have their own strategy and adopt the one they consider the best. Thank you very much. Thank you, Doctor. Next question is by Orville Williams from Antigua Observer in English, and it reads as follows.
Recommended do's and don'ts for countries upon reaching herd immunity where public health and social protocols are concerned. Dr. Alighieri?
Yes, thank you for this question from the Antigua Observer. The concept of herd immunity could be misunderstood. This is a theoretical concept that implies some important caveats, as, for example, the existence of a very large population that is perfectly mixed, and that is hardly ever the case. This herd immunity is also unlikely to be a fixed threshold, and it will vary depending on several factors, such as how much people usually interact, which SARS-CoV-2 variants dominate, and how immunity wanes in the population. This is why we should not make public health policies based on whether we think herd immunity has been reached or not. For several months, PAHO has advocated for the adjustment of a combination of public health and social measures depending on the epidemiological situation. That remains our main recommendation going forward. Even when community transmission diminishes, we can still experience outbreaks under particular situations, such as in confined environments or from super spreading events. We do expect that as vaccination coverage increases substantially and uniformly across all age groups, vaccination will gradually contribute to the population immunity and thus contribute to decrease in transmission. However, the extent to which vaccination will contribute to that is still an open question, primarily because we see with great concern how vaccine hesitancy is prevalent, especially in the Caribbean. So in this context, people who are eligible for vaccination and are offered vaccination should embrace this opportunity as a way to protect themselves from serious consequences and to protect others in their families and in their communities. I hope I have answered the concerns of the journalist in Antigua and Barbuda. Thank you.
Muchas gracias, doctor, y ya estamos llegando al final
Thank
de
you
la
very much, Doctor. And we're reaching the end of today's session. The next question is by Laura Barros from the EFE agency. She's saying that the region of the Americas is facing a challenge with mass migration, and she's asking what are PAHO's recommendations to the countries in the region to help these individuals that are moving in the midst of a pandemic. Dr. Etienne.
Question, as all of us know, in our region, we have seen mass migration in the Northern Triangle, but also originating from Venezuela. This mass migration has generated increased health needs of both the migrant population and the host communities. And some of those needs, the main ones include maternal and child health care, emergency care, the prevention and control of communicable diseases, vaccination, including vaccination against COVID-19 and others. In areas near borders and in entry points, countries need to prepare health services so there is enough staff, equipment, supplies, especially for maternal and child care, medical emergencies that are related to injuries, which may very well occur during travel, acute events, and referral of patients to more complex health facilities if and when necessary. So PAHO, with the financial cooperation of the United States of America, Canada, the European Union, and others, has facilitated the provision of services for more than 2 million migrants. And these services include immunizations, consultations, emergencies, mental health, and others. We have worked to support national health authorities in Brazil, Colombia, Ecuador, and Peru. We have strengthened some 112 first-level care facilities and 84 hospitals by delivering equipment, medicines, and supplies, and have supported 18 public health laboratories and 25 emergency operations centers. Some 16,000 health workers and more than 20,000 community agents were also trained in face-to-face workshops and virtual courses. PAHO is facilitating the coordination of the international health response in the countries of the region. And we lead the health group of interagency regional platforms for refugees and migrants of Venezuela. We are also actively participating in the Quito process, promoting the incorporation of migrant healthcare into the policies and plans of the countries to ensure access to health services for the host communities and the migrant population as well. The commitment of countries to universal health access and universal health coverage requires that we address the health needs of migrants. And I'm very grateful to the member states of our region that have made efforts to ensure that the health needs of migrants are planned for and are met. This is a responsibility that we have as a general community within the region. So I thank you again for joining us today. And let me remind you, please get vaccinated ASAP as soon as possible. And please continue to observe the public health measures. We can win this pandemic, but only if we follow the measures and accept the measures that are available to us, and only if we do it together. So thank you again for today.
Muchas gracias, doctora Etienne.
Thank you very much, Dr. Etienne. We have reached the end of our session today, and please remember that you can find further information on COVID-19 and PAHO's work, as well as the situation of vaccination, status of vaccination in the Americas in our website, www.paho.org. So see you next week. Thank you for connecting. Please let us take care of ourselves. Greetings from Washington.